people who would come home to their own homes and strip down in their garage.
Yeah.
And would not have any contact with their families.
Yep.
They slept in separate rooms, ate with utensils that were separate, that kind of thing.
And that's a mental toll all by itself. I mean,
yeah, I don't think the public realized what we had to do to keep going.
This is your co-host Detox, and I am here usually with MZ, but MZ had to step out for a little bit. But in the meantime, we brought our other sassy friend back with us, Leslie Yancey. Hey, Leslie.
Hello.
Hello. Leslie's a respiratory therapist by trade, but we bring her with us because she brings the sass, and she has about 800 hilarious stories, and she is just so much fun to be with. So we brought you on today. Jump in with us because we're going to talk about something a little different. Right, Leslie?
Absolutely.
So we're going to be talking about, we're going to talk about hospice, but we're not talking about hospice itself. We're talking about hospice nursing. Because this whole show is geared for the medical professionals, right? Think of the break room talk, not getting your CEU conversation, right? You know what kind of conversation that is, Leslie, right?
Absolutely. Yep.
So today we're going to bring on a fellow podcaster, Helen Bauer. Hello, Helen. How are you?
Hello. I'm great. How are you?
I'm good. And Helen, you are as wise as Leslie and I are. You're in that 30-year range in the medical community as a nurse.
Yep. I've put my time in.
You have? You own a couple T-shirts, correct?
You got it. Yes.
And so Helen and I met through doing a promo of Whole Care Network and Coming Home Well. She is hilarious, has a huge background, and we just want to kind of get into your story and how you went from getting into nursing, staying in nursing this long, commended, and getting into hospice care. How did all that transpire? Where'd you start?
I've never had one of those stories that was, I felt a calling or a mission, Florence Nightingale type personality. If anybody was calling, I did not answer. I never had that. I knew it would be a full-time job. There's longevity because there will always be sick people. And so I just went into it with a very practical mindset. I worked in the hospital for 2 years, gained some skills there. And then I went into community-based care, doing home health for years, 13, 14 years, wow, and doing home infusion. And then very inadvertently stumbled into hospice. Had no idea what it was like to work with people at end of life. I had actually only seen one person die in the hospital and never anybody dying at home, in their own home. And so 14 years later, I'm hooked. I love it. I will work out the rest of my career like this in this field.
What led you? So what did you do in the hospital for nursing? What was just med surg or?
I worked in a cardiac unit. And because I was brand new, I did what they call floating. They pull you, basically you're low man on the totem pole when it comes to seniority. So they pull you to all these different floors. And I actually hated that because I never knew where I would be from shift to shift. But there's a lot of experience and a lot of exposure to be gained there. You get to see a lot of different stuff and you learn from all these other seasoned nurses that are working. And that part I really benefited from. But when I had kids, doing shift work like that was really difficult. So that's when I went into community care.
Floating to me is the fastest way to ramp up your anxiety disorder.
I think back on it now. It's been 30 years. I can still feel the anxiety from doing it.
Yeah, you never know what you're going to end up with.
Oh my gosh. And not everybody was welcoming to having a brand new nurse who didn't know the unit, was constantly asking questions. So you have to choose, do I harm this patient? Do I make a mistake? Or do I ask a question of a coworker who's a little on the cranky side? and doesn't want to respond because she's busy and doesn't have time to talk.
Kudos to you for doing float at a brand new nurse level, because that's the fastest way to anxiety disorder. Holy shit.
Yeah, I wouldn't go back and relive that.
Nah.
And I think it taught me a really good lesson about how the nursing profession works, because we're our own worst enemy.
Or
When it comes
bitchy.
to new nurses, we are so happy you're a nurse. And then we're just going to be mean as hell to you the
Yeah.
entire time.
Oh.
Until we feel like somehow you've qualified by the
You've
time
earned
that
it.
you've worked. Yes,
Yes.
that you have to earn decent, being treated
Yeah.
decently. Really?
We were the
Yeah.
found.
And then we wonder why the industry is so short.
Yeah.
Why we
Yeah.
are so short staffed. It's because we act like jerks to the people who are brand new coming in.
We're the founders of hazing. Seriously.
Exactly.
Absolutely.
We were
It's a professional hazing.
It is. Yeah. And they don't do anything about it. I mean,
That actually came up when we were doing the violence in the workplace.
oh,
the-
yeah.
More people said to me, you need to be doing or addressing the conversation of, us eating our young.
Oh, that's
Yeah.
happening. We're going to have
Aggression in the workplace,
Yes.
hostility.
Yes.
Yeah, absolutely.
Yeah, it's insanity. And honestly, it's funny, Helen, you said that you didn't come in like, oh, I'm going to be a nurse and I'm going to save people. 'Cause I was like you.
Yeah.
I'm all like, I want a job that I can travel with, make decent money, and I needed a way out that was secure. And sure, why not pick the hardest bachelor's degree? Why not? So off I went and did it. I don't regret my choice. I mean, I liked being a nurse, but I definitely was more pragmatic and hated that eating, like, knock you down, you're not good enough. I've never understood that. So when you did that and then you left and went into community care nursing, did you ever do anything like that? Does respiratory therapy go out in the field?
Yes.
Do
Actually,
you?
yeah, home health is big for respiratory because of BiPAPs, CPAPs.
Yeah.
Yeah, home ventilation, oxygen. That's
Yeah.
is actually really big in the respiratory field.
Did you go out? Have you ever done the community work?
I haven't. I think I may have done some during clinicals.
Yeah.
But that's not for me. And I have several friends that do it now and absolutely love it, especially like home ventilators. When kids are going home on ventilators,
Yeah, it's
they will
no
go set them
joke.
up and they will do the visits, and they absolutely love it.
Oh, no.
Me personally, going into someone's home, especially in the area that I live in, it's not for me.
I have been in those homes.
Yes. Well, I live in Appalachia, so that's just not something. I think I would see so many situations that I would feel like I needed to do extra help in, just because the education isn't always there and what that patient needs isn't always available. And I think mentally that would be extremely hard to do.
Oh, it is. It is
Yes.
the moral fatigue that you experience because,
Yes.
we come in, especially with hospice, because it's holistic care, mind, body, spirit. We do collaborate with people like respiratory therapists and dietitian and physical therapists. But for the most part, almost all of the care is provided by that core team, a doctor, a nurse, a social worker, and a chaplain. And we look at everything and we're like, we got to fix this.
Right.
If a patient's not safe, we fix it. If there are bed bugs, we figure out how to fix it.
Yeah.
And when I first went into hospice, I remember coming home and telling my husband, these people are sick in an obscene type of way. I had never seen disease so advanced, cancer that was in 5 or 6 different sites in the body, pain, emaciated patients, end-stage Alzheimer's patients that were bedbound and nonverbal. I had just never seen that kind of stuff, because in home health, it's all about, we're going to be there for a very short period of time, do the prescribed plan of care, get you up on your feet, make you independent, and send you off healthier than you were before. And in hospice, that's not the goal.
Right.
Yeah. So going into people's homes and being inserted not only into their living environment, but
Right.
into their family dynamics
Yeah.
and all of their relational history and disease trajectory, they've lived a big life before we even got there for the most part,
Right.
unless you do pediatric hospice. That's a different type of care. But to be inserted inside someone's life like that in a very personal way, there's a lot of autonomy that's needed. And I think working in the hospital got me ready for that. I got the skills that I needed. And then working in home health and hospice, you learn to work by yourself. You learn how to reach out when you need to connect. But you have to be ready to have a work environment where you don't sit down because the furniture is filthy. When you get through at the end of the day, you realize that you have some sort of, I'm going to say water, some sort of liquid stain on the knees of your pants, and you didn't kneel down in your own urine. So it was somebody else's, and you have to get used to that and have a certain tolerance of it. You have to be willing. You have to have a stomach. You have to be able to stomach some of the stuff.
So I would assume, Helen, when you go in, you probably have to learn to prioritize what the needs are at the time. Because when you walk into a situation like that, I would think it would be overwhelming to say, oh my gosh, we have all of these factors that are interfering with this patient's wellness. What do I attack first? I mean, is that kind of the mindset that you have to go into that?
Oh, absolutely. Absolutely. So first thing you look at a patient is if they're in pain or they can't breathe, right? You want to get those major symptoms because first and foremost, so say the house is filthy. If a patient can't breathe comfortably or their pain's not controlled, nobody cares about how dirty the house is.
Air seems to be important.
Absolutely. Yeah. Yeah. You have to prioritize. And the good thing is working with an interdisciplinary team, we each bring these skills that are so necessary. If we have a patient with no clean running water, no air conditioning, because I live in the South, that's a huge thing.
Right.
That's what your social worker is for. You need a family conference to talk about advanced care planning or, there are horrible family dynamics. Your social worker and your chaplain, they deal with the psychosocial and the spiritual side. Patient's been incarcerated or is disconnected from family. That's your chaplain, to deal with guilt and regret and relational issues. Fortunately, the nurse doesn't have to do so much of that. All of it overlaps in a certain way. Everybody's responsible for assessing pain, that kind of thing. But without the team, the nurse would never make it through this.
I can't. Yeah, that's heavy. It's a heavy load to do it all by yourself. Well, let me ask this: hospice itself, even within the medical community, I think there's still some level of understanding. You say hospice, you say you're going to die, right? I mean, that's what everybody immediately says. But if you talk to hospice, one of the first things I will always hear them say is, palliative care doesn't always mean end of life. So will you clarify that first?
So there's so much confusion around palliative care.
Yes.
Because palliative care is the new specialty on the block.
Right.
It's been around for a little bit, but not as long as the other silos of healthcare. So this is the way I always explain it. So palliation is to comfort, right? To create comfort, to make a patient comfortable. So palliative care is always part of hospice, right? We always want our patients to be comfortable, but not all palliative care is hospice. You can have palliative care without being at end of life.
Right.
And now that's what they recommend. When you start out with a chronic illness or you receive cancer treatment, you have a serious illness or a life-limiting illness, you should be starting palliative care way early before you get to hospice. But palliative care is incorporated into hospice care. So it's just confusing.
So palliative care in of itself is just kind of getting life into the optimal level before there's any more decline. Would that be a fair assessment?
Yes. And you can receive treatment.
Right.
That's where it differs from hospice care. You can receive aggressive treatment and have palliative care, whereas in hospice, you're receiving palliative care, but you're not pursuing aggressive treatment at that point.
Because now we're at end of life. Now we've hit end of life.
Right. Treatment's not effective, or you've maxed out on it, or you just don't want any more.
Right. And you've decided, okay. So And really the goal isn't, like Bullets to Bedpans is all geared towards our perspective, right? So I still like to clear up what hospice is, because like I was saying earlier, like hospice care is kind of like obstetrics. Like in the medical community, they're like, oh, that's that other medical stuff. Like we don't do vaginas and we don't do that death thing. Like, sorry. Yeah, like
and the
like,
people
Our patients aren't
the
supposed
people
to
that
die
do
anyway.
the people that do are just not socially acceptable.
right. Yeah, they're just
I do podcasts.
right. Here we are doing podcasts. Right?
And we talk about death excessively.
Oh my
Obsessively.
God. Let me tell you.
Yeah, it's sick.
And being medical, I'm going to go a little sideways here, but being medical, we already have a different perspective of death and life.
Yeah.
And let me tell you, like I used to say, and people thought I was crazy when I said this, like when a labor and delivery nurse had a baby, they were just like actually surprised, like, oh, look, I get a baby to term, right? Because there's so many miscarriages. Like it's more common, and we see that, right? We see more of that than any community would see that. So for us, we're like, well, hot damn, look at that. We made a baby and we made it all the way through. There you go, right? So we kind of have a little bit of that warped sense of humor, and the same side with death, right? And so I've been in scenarios, and I'll have people, family and friends, they're like, oh, she's a nurse, she must know. And I'm like, okay. And so I'll get these calls like, well, that it's terminal and we don't know how much longer. And what do you think? Oh, well, like, I can't see them. I'm not there. It's not my special. Hey, I don't know. Your guess is as good as mine at this point, right? Like, I don't know. But there's certain things that I've learned through my friends that are nurses, like end of life stuff, when they start seeing, what is it called? When they start seeing family and friends that have passed already.
Visioning,
yeah, and stuff like that. So I'll lead to the story is that I had somebody that had called me. It was a friend. Her mom was declining. She was very much older, 93 or so, had a good long life, battling cancer. And she calls me up. We talked about every week or so, and I would just check and see how she was doing. And my perspective was, if you feel this is the end, then make it her best end, right? So play the music or the TV show, or have the smells that she remembers, talk to her about her past, get those last memories in, all that stuff, right? Celebrate it. Don't be afraid of it, right? Because it's going to happen. So let's do it in a good way. So she calls me up and she says, hey, so there's some brown fluid coming out of her. And I was like, okay, where?
Which orifice?
Well, underneath or bottom. I'm like, okay, is it a rectum? Do you think because two different things. Did she have liquid poop, or do we have urine and kidneys are failing? What are we? I'm not sure. It might be urine. And so I started talking with him like, okay, well, if it is, then, this would be a time to let your hospice nurse, because she was in hospice, let them know what you're seeing, I said, because if it is, I said, then there is a chance that what will happen next is that she might slip into an unconsciousness, And she's like, what does that look like? And I said, well, they just kind of look like they're sleeping and they're not really responding to you. And then she's like, I think we're there.
Oh, my word.
And I was like, okay, you should call your hospice team about now. So, and I go, is your family there? And she says, they're coming tomorrow morning. And I said, okay, that's good. At noon the next day, I got a text she had passed away. So, and family was there, hospice was there, but I was giggling in a nurse medical way, all inappropriate humor. And I was gently giggling at her surprise, like, oh, I think we're there. Like, she identified.
That's pretty good assessment. You didn't get into, is the baby crowning?
Oh my
That's
God. I've done that one too. That's not as calm, let me tell you, like, holy Lord. So from your perspective as a nurse, you've been in this, 14 years, and you said you want to keep going, which I, by myself, think that's impressive, because you are not just dealing with the person. If anything, this is just my opinion, sometimes the patient's the easiest one to handle.
Oh, yeah.
How is it from your perspective when you are doing this day after day? Like this is the grind, so to speak. Like how do you cope, or what's your care, maladaptive or adaptive?
I've had some of both. So I'm not in the field anymore. I haven't been at the bedside for several years, but I still speak the language. I work as a consultant, so I'm constantly reading, talking, interviewing, the podcast for 7 years, talking about death and dying and grief and bereavement and how we handle it as professionals and how we deal with patients and their families. And I had a social worker teach me early on about the dreaded FD, she called it, and it was family dynamics, which, holy crap, people are crazy, right?
Amen, sister.
I'm telling you, that's my theory about human behavior. Forget Freud and all that other complicated, all those people. People are nuts. That is what it comes down to. And that includes us too.
Mm-hmm. That's how we cope.
So I found I had some personal rituals that worked really well for me, and they sort of developed naturally. Now, having had several years underneath my belt, I know more about myself and what I need as far as how to take care of myself. But at the end of the day, I would come home, and for infection control purposes, right? You've been in all these different houses. I come home to my own house with my husband and my children, and I would strip down out of my scrubs and immediately take my shower. I like to, it wasn't just
that was pre-COVID too, wasn't it?
Yes, I hear stories about friends during COVID, who would come home because we were still seeing patients in the home.
Wow.
People who would come home to their own homes and strip down in their garage.
Yeah.
And would not have any contact with their families.
Yep.
They slept in separate rooms, ate with utensils that were separate, that kind of thing.
And that's a mental toll all by itself. I mean,
yeah, I don't think the public realized what we had to do to keep going. The hospital is, and this enclosed, protected environment, it became encapsulated and protected. But for community-based care, especially for those who were dying, we stripped down the care, unfortunately. Chaplains and social workers did not go in. They weren't making face-to-face visits, but our nursing clinicians still were. Our aides were still making visits in a lot of homes as well. So you learn these rituals to take care of yourself. And for me, it was to get clean, and it was a washing off of the day.
Yeah.
Right.
Getting out of that uniform, not just to change clothes, but to change my role and my identity. I'm back in my personal life and who I am.
Yeah, I get it completely, because that's what I did when I came home. I was like, I need a shower.
But I didn't realize it was a ritual until later on. It was a washing off of the day. It was a mental and a psychological coping mechanism that I did for myself. I just didn't know it when I was doing it. I just wanted to be clean.
Yeah. Well, go ahead, Leslie.
Helen, that makes me think, like, how supportive was or is your spouse with your role?
My husband does not work in healthcare, and he would listen to the stories, God help him. And, of course, I didn't tell my kids what I was doing. Right. I think eventually they figured out I worked with people who were dying. My husband has always been very, very tolerant, because as a field clinician, I was going out in the middle of the night. He wouldn't know where I was. I would get phone calls. I had a pager way back when, that would beep and wake us both up in the middle of the night. He's always been really, really tolerant. And he's also a very quiet person. So where I needed to talk, there was space for that.
Good.
One thing I did learn, though, was I was not comfortable sharing with him a lot of the things that I experienced.
Because he couldn't relate. It wasn't relatable for him.
Right. He couldn't relate to it. And the other thing was, it was sort of a contamination of my personal life. The things that really bothered me, that I saw that were upsetting, there was a lot of suffering or something like that. I didn't talk to my husband about that. He could not get it. It was sometimes it was horribly gross. You know, we see a lot of nasty stuff. And you really have to have somebody who has seen those things. So you talk to your coworkers and your colleagues and you're saying, you're not going to believe the SHIT that I saw today was horrible. And this is a person who can relate. And they say, tell me, you know, I saw this patient last week with you. And they totally get it.
Go ahead,
I think
Leslie.
one thing that I actually did a podcast years ago, and it was the same thing. It was organic. I didn't know what was going to be asked of me. And one thing that he started off with is he had been a medic and he had done rotations with a respiratory therapist. And one thing that stuck in his mind was RTs going in and terminally extubating patients. Yeah. And when he said that to me, you know, I'd been a therapist at that point 20 years. I never registered that in my brain as being something that other professions didn't have to do. But that was something that was expected of me. And I worked critical care and it could have been a 16, 17-year-old trauma patient. It could have been a child. It could have been, and the nurse went in and told the family, respiratory is going to come. They're going to remove that tube. And then it was my responsibility to, and this is where that grossness comes in. You know, I didn't want my patient gurgling. I didn't want my patient struggling, because at that point, then my focus was on the family. I didn't want them to be traumatized. So I would have them step out. And then as I've kind of went through this and you sit back and you try to process those things and you think, wow, how abnormal is that I am sticking, you know, a Yonkauer up someone's nose, down the back of their throat as far as I possibly could, so that the family isn't traumatized by liquids or gurgles or unnatural sounds. And, you know, I needed to make sure that patient wasn't struggling. That's where your support with your nursing staff came in. Hey, let's bolus this patient. I don't want that family. And I sit back now and I think I've done that for so many years. And how abnormal is that the general public has no understanding of what that's like?
Yeah, that's 10 kinds of jacked up.
Totally.
I mean, let's be real. Let's be real. There are things that we do in nursing and healthcare. It totally is.
It is.
If you could tell people, okay, so here's the process. We do terminal extubation in the home as well.
Yeah.
Sometimes we do it in the hospital if a patient is on hospice in the hospital because their care can't be managed at home. We do that. Yeah. And the whole hospice team is involved. But there is a huge process that goes into processing those events and setting them up. It takes a team. You've got your respiratory department, your nursing, all these different departments and clinicians that manage all this stuff. And we couldn't do it without each other, and we shouldn't do it without each other. But after you get finished, if you look at what that event is, you have just helped someone die.
Yes.
Holy shit.
Yeah.
And respectfully. So that was another thing, is you're wiping their face, you're combing their hair, you know, making sure that their eyes, you want them to be as presentable as possible during those last moments. And sometimes it's a complete shit show. You're going in, you're trying to hurry, there may be a very, very small window between that extubation and that death, and you want that family to be able to come back in to be there for those moments. Right. So, you know, and to your point earlier, talking about newbies, I don't know how many times I would have new nurses. They would be totally flabbergasted. Is that normal? What should we be doing this? And I'm like, just bolus. Like,
try to stop the Chain Stokes breathing.
We
medication
struggle, and then you get a new nurse who's just as shocked as the family is.
Oh yeah. You're gonna medicate the patient. The patient is not your concern. You can't medicate the family.
Absolutely.
Right. My first death, I will never ever forget. I was waiting to come in the military, been a nurse a whole whopping 2 months, I think. working at my hometown hospital, a little tiny thing, and a gentleman comes in there that has terminal brain cancer, and we're on the terminal end of it, right? We're just managing him, and the doctor had written an order for milligram morphine IV every increased by 1 milligram hourly PRN pain, right? Okay.
Yeah.
We can do that, right? So 12-hour shift. I wasn't every hour, but near the end I was up, and I think by the time I left, if I'm not mistaken, he was somewhere near 10 milligrams. I mean, like, come on. Well, anyways, come in the next day. Guess what? He passed away. I was convinced that I killed this guy, right? I went home. I was upset. My mom is looking at me and I am in tears, and I'm like, I killed him. How did you kill him? And I'm like, the morphine. And why were you giving it? My mom is sitting there looking at me like she already got it, right? And I was not getting this. And she's like, Donna. And I said, yeah, was he gonna die anyway? Yes. I'm not processing it. I am just beside myself. I killed him. And then once I processed that, I was like, oh, wait a minute. I just let his body do what it was going to be doing, without that struggle, right? Without that horrible fight. And any of us seen Chain Stokes, you only need to see it once to remember what Chain Stokes breathing looks like, right? That's the most horrific I saw it in nursing school, and
guppy breathing.
Huh?
Yeah.
Guppy breathing.
Yeah. And I mean, the lady did that whole, and I thought that was it, right? So I'm like, all right, we're done, right? And all of a sudden, I was like, holy shit. I didn't know what had happened. And I was that nursing student that you're just looking at like, it's okay. This is normal. Like we're just,
But so that's the situation that families struggle with in the home in hospice.
Right.
We're going to teach you how to work, how to give these medications. Oh, but guess what? We're not going to be here when you give it.
Right.
Because we don't stay here. That's one of the big myths about hospice care in the United States is once somebody elects chooses hospice care, that a hospice person, a nurse is going to be with you when things, towards the end and somebody will be there. No, it's hit or miss. We're going to teach you how to do all these things, empower you, educate you. However, you're probably going to be scared.
Right.
And once you get mom or dad or whoever comfortable, those body systems and those processes that are made to shut themselves down naturally, your body already knows how to die.
Right.
They're going to get comfortable enough to do that. And so I've had families say, I gave him the morphine and he died an hour later. That's right.
Right.
You got him comfortable.
Yeah.
But there's a lot of fear around that. So here's a crazy story. My father-in-law was on hospice 2 years ago in the middle of the pandemic. And he had end-stage Alzheimer's and was on hospice, had been on hospice, I guess, 4 months or so, and was having all the trouble swallowing, didn't recognize his family. He was pretty much nonverbal. And he had a stroke. He had a stroke, which was a gift. So for anybody who understands Alzheimer's disease, the swallowing becomes an issue. Do you feed? Do you modify the feeding? A lot of times as they get closer to death, the body can't process the food and they don't want to eat. They lose weight even though they're getting Ensure or supplements. And it's a very, very sticky time to figure out how to care for a patient. Mm-hmm. They aspirate. Leslie will tell you this, aspiration pneumonia is a nasty thing, hard to treat. So my father-in-law, we were blessed because he had a stroke that put him in the bed, unable to swallow, and precipitated his death.
Right.
So he began to have some panting. He began to breathe. He would be at 38, 40 breaths a minute, which is a lot of laboring. It's unnecessary, but that was just how his body was shutting itself down. So we began using morphine according to the instructions that the hospice nurse gave, and we had to up it. and then we had to up it again. And it was all within the parameters of what the doctor prescribed
Right.
and how the hospice nurse, but I came home and I remember thinking, what if he dies after we up this dose?
Yeah.
What if he dies? Because I was supporting my husband and his mom and telling them, it's okay to up the dose. It's safe to do this. There's no threshold on morphine. It's okay to do this. It'll relax his breathing. It's a side effect of
Right.
the morphine, and that's how we use it. We're not using it so much for pain in this case. We're using it for his breathing. But I remember thinking, what if we killed him with the morphine?
Yeah. You can't
Right.
help not think that, because that's how I felt.
Yeah.
It was like,
Yeah.
I did that. And then you're like, did you? Like, and you really break that down. No, you relaxed the body so the body
Yeah.
could
So it
do
can
what
do
it
what it-
needed to do. And did we
Absolutely.
expedite that? Yes, we expedited it. If we didn't, we would watch a person struggle with pain, agonizing death, and not be able to go peacefully.
Well, so really, I don't think we expedite anything.
No.
I wouldn't use that
think-
word particularly. We calm things so the processes could go forward and move.
Well, that's fair
But
enough.
see,
Yeah.
Yeah, to me, expedite means to speed things along, and I don't think the meds do that.
Well, I think that, I guess maybe expedite's not the right word. Maybe it's more because I just think that if they're fighting this whole time, I don't know. You're right. Maybe we're actually not expediting, because if they're fighting pain and they're wearing themselves out, maybe that makes it go quicker. I mean, it could
It's
be
just
that way too.
suffering.
Yeah.
It's just suffering while the process happens, and it's unnecessary.
Right.
Yeah.
Yeah.
So one thing because I always work critical care, and I worked at a trauma hospital. So of course there were tons of situations where deaths seemed very untimely, or they were very young, or there were different things and horrible situations that surrounded death. And mentally, how I had to, and I didn't figure this out until I was later in my career, but to not carry that with me, I had to process the fact that nothing I did sped up someone's time leaving this earth. That was above, that had nothing to do with me. I was used to take care of a patient, and whether it be a mistake, whether it be shoulda, coulda, woulda, I don't get to decide how long someone stays on this earth. I was just used to care for that person, because I think that mentally we carry so much of that responsibility, and it's not ours to carry as caregivers. And that's really how I had to start looking at things, and I had to encourage other caregivers, because I think that we have a bad call, or we have a patient that we worked and we don't understand why they didn't make it. And it is not our call ever. I think that we are put in situations, and I don't know, Helen, how you process it, how other nurses that you've been around with have learned to process that, but how do you deal with death, or that person that says, oh, I gave that morphine and they died within 10 minutes? Like, how do you address those things?
I'm like you. I think you have to realize that as a professional caregiver, because that's what we are as nurses and therapists, we are placed with a purpose at the bedside. Yes, I guess the extreme would be I extubated a patient, a terminal extubation, and that did precipitate in the patient's death. But when you look at all the mechanized, medicalized things that we put in the way of people's natural dying process, we realize that we bring our skills to the comfort and the palliation and the support of a patient. And that, to me, is way bigger.
Right.
Is way bigger than the quote unquote part we played in a death.
Yes.
The death was coming anyway. I think that's a really good way of thinking about it. But when you're new to things and you haven't experienced it, Donna, like what you were saying when you went home that day and you told your mother, I may have killed this patient. I think we all go through moments like that, even as seasoned professionals.
Yeah.
Because you have to look at this role it's really a weird dichotomy for us because you have to take it casually at some point. This is part of my job. I do this every day because otherwise nobody would ever do this work.
Absolutely. Yeah.
It's crazy.
Here's my question. Do you think that nurses in or medical people, because there's more than just nursing in hospice care, but do you think they are a different breed and I'm comparing this to what we had talked about eating their own. She's smiling already. She knows where I'm going. Like compared to this whole eat your own, kind of personality, do you think nurses and medical people that get into hospice are a different breed?
I would like to say we are. I would like to say we mentor better.
Are you more welcoming, like new nurses coming in?
I want to say yes, because, hospice teams are so different.
Yeah.
Hospice teams, it's very much a work family. And because it's kind of like the military, the brotherhood that's created by serving in these intense circumstances.
Yeah.
Hospice culture is very much the same way. So Leslie, you and I could be caring for the same patient. We've experienced a traumatic event. We've watched it, and we carry a little bit of that as compassion fatigue or secondary grief with us through each one. So I think the way we support each other is different and deeper, maybe.
Nicer.
Yeah, I have to say yes, because after doing this for 33 years, 34 years, I've never worked in a silo of healthcare nursing where I felt a connection and experienced the kind of support that I experienced from my hospice team, hospice colleagues. So it's really just different, at least in my opinion.
Yeah. You mentioned military, and it's funny because military, we don't have hospice nursing. Like, you get shot and you either get killed or we pick the bullet out of your butt and then we sew you up and then you get better and you go back to it, right? There's really no in between here. I mean, and if you do get to that place of terminal, we have, people that had cancer and stuff like that. Hospice care comes from the civilian side. We don't have military hospice.
Yeah.
Yeah. So it's a foreign.
A little weird.
Yeah.
That is.
Yeah. To think about that. Do you take care of a lot of veterans? Have you taken care of veterans?
I have. So here's an interesting statistic. If you are nerdy and
we're nerdy,
I am a little statisticky. For Medicare is the major insurance, the major benefit for hospice care in the United States. 1 in 4 Medicare hospice patients is a U.S. military veteran.
Jeez.
Wow. 1 in 4, 25% of the patients we care for that are Medicare hospice patients, and that's the majority of our patients, they are military vets.
But they're going to decline because now we just had the boomers, we're in this boomer...
Right. The silver tsunami.
Yeah. Silver tsunami. I like that.
Yeah. There's an influx of these folks.
Yeah.
I'm right on the cusp. I'm on the edge. I'm a year younger than the boomer boundary.
Jeez, you don't look that old.
Thank you.
Dang, girl.
Thank you.
That olive olay is working for you.
I will take that compliment. But yeah, I've worked with a lot of veterans, and of course they've changed through the years, because it used to be that we had the World War I guys.
Right.
And then the World War II veterans, and
we're almost out of those.
We are.
Are they done?
I was on a team that honored a Pearl Harbor veteran.
Wow.
Very advanced age, and this very revered service that he had serving at Pearl Harbor and being in the military. And he was on our service when Pearl Harbor Day happened, and several of the people went out. We have a program called We Honor Veterans that hospice agencies can participate in. And what they do is they get veterans from that same branch of the military to go as volunteers to visit the patient. They are in uniform, hopefully the uniform from that era.
Nice.
So there's recognition and connection, and the military service is honored. And we were able to film this gentleman's, they did a little service. They presented him with a flag and a pin from his branch of the service on Pearl Harbor Day.
Oh, that's awesome.
And then he died a few weeks later. And so it was this incredible meaning that we were able to make for his family. and for the gentleman. It's amazing to work with veterans. For me, as a middle-aged white lady that has never been in the military, and up until a few years ago had never had anybody in my family that was in the military, it can be hard to relate.
Yes.
It really can, to their experiences.
Yeah.
But I remember I had an older gentleman who had served in World War II. He was a character, very country guy, lived way out in the middle of nowhere with his daughter and son-in-law on a big ranch. They had a cattle ranch, very stereotypical Texas. And he had been an ambulance driver. And he was
in the military?
He was in the military.
Oh, okay.
And he was so funny. When he needed to go to the bathroom, he would get up with his walker and he would say, I'm going to go to the post office. I need to go to the post office. It took me a long time. I asked his daughter, I said, is he confused? You know, where's he going? She said, oh, that's his code for saying he needs to go to the bathroom. Because he was an older gentleman. He was very polite. He didn't want to say, I got to go to the bathroom. I need to pee. You know, he didn't want to say that. Yeah, the ambulance driving thing was a big deal because it became part of his reality when he got closer to the end of his life. He began to hallucinate some, didn't know where he was easily disoriented. And at night, if there were car lights that would pass outside the window, he would say, there's an ambulance. I got to go. I need to drive the ambulance. And he talked a lot about seeing dead children.
Oh, I bet.
His family said they didn't know a whole lot of details. He had been very, very close and private about his military service.
Most of them were. The ones that I've seen. I had a great uncle that was D-Day. And so you've all seen Saving Private Ryan when they show them climbing the cliffs. He was one of the cliff climbers. And I didn't know for years. He was just the crazy old drunk Uncle Joe. That's how he was always seen. And, you know, come to find out, he just had repressed all that. And that's why he was, you know, drinking like a fiend and everything else. So, yeah, a lot of those guys are really quiet. And do you notice, when you're dealing with veteran end of life, is there anything significantly different than, I don't know, civilian end of life? I mean, and how they are coming to the end of their life? Just curiosity.
I think a lot of times they have stories that they haven't told.
And they want to tell them? They want to tell them? Yeah.
They do, to a certain extent. It depends, I think, on the level of trauma and the intensity.
Yeah.
Because, so for instance, Vietnam vets, a lot of those guys came back and there was incredible shame.
Yes.
And shaming, you know, there was a lot of rejection from the American public. And so the stories and the trauma that they experienced, they never shared it with anybody and they internalized it. You know, a lot of addicted behaviors, a lot of alcoholism, drug use, that kind of thing. And at end of life, they might loosen and share something that I would have families tell me, I'd never heard my dad say that before.
Yeah.
Right.
I never knew he did that.
So, Helen, I have a question. How do you, since you don't have, so in the hospital setting, I have someone who relieves me, who takes my spot. How do you, as you're going in and doing the visits, how do you draw that line between I need to stay here and sit with this person or share with this person and go back home? I mean, I'm sure that, like, to me, that sounds like that would be a constant struggle as to when do I cut off the time here?
Yeah. Yeah. So this is what I'll say about that line. It's very, very wide. And it's very gray.
Yeah.
Boundaries for people who work in community-based hospice, it's a real challenge. It is a real challenge because we get to know these people intimately.
Right.
Yeah.
We are in their homes. We see pictures of their grandchildren and people tell you stories. In the hospital, like Leslie, I'm looking behind you, I see things mounted on your wall, diplomas or certificates, certifications.
Yeah.
She's missing her calendar, though, from the firemen. She has to get that up.
We're still waiting to get our
take
fireman
that down.
calendar.
Well, so when you're in someone's home, you get to see all these things and they're pieces of their lives. And those are the conversations you have. It's not all about, what's your blood pressure? When was the last time you pooped?
Right.
Although it's a lot about when you pooped. We talk about poop a lot. But so in the hospital, you you
more
are
sterile.
stripped of your identity.
Yeah.
Yes. When you're inserted into their lives and their environment and their family and their relationships the way we are, it is much harder to disconnect
Right.
and let go of that. You have to learn that if you want to do it well and you want to do it for any length of time, you've got to disconnect and honor yourself as an individual.
So how do you do that? That's actually
Right.
was going to be my question as we kind of start winding down, is somebody that is curious about getting into hospice and they already struggle with boundaries, nursing, then
Yeah.
what advice do you give them on how to do something like this where you have become part of their family and then they lose their family member, but you lost your patient, but it's a patient plus, right? It's not the sterile environment.
Right.
They come up and do the whole dressing of them, and it goes down in the morgue, and that's that. You are in their house now. How do you, as the nurse, handle all of that? What advice would you give to a nurse that's wanting to do hospice?
You know, we overuse that term self-care so much, but I think self-care after the pandemic has changed. We have an awareness. It's not vacations, it's not a manicure, it's not a massage.
Right.
It's a minute to minute, hour to hour. You touch a doorknob to go in a patient's room, you take a deep breath and you say, I'm here to do good. Let me do no harm. Let me leave them more comfortable than when I came in. So that kind of self-care, some self-awareness, trying to get that 10,000 foot view from above, which is really hard when you're thinking, oh, I could mow this patient's yard. I don't have anything going on this weekend. Yeah, that's a lack of a boundary. Yeah, that's a lack of a boundary.
Very
It
good
sounds
point.
wonderful and
Yeah, I
benevolent.
totally get it.
Yeah. So I think being self-aware and practicing great self-care, very robust, individualized self-care. But the other thing I think is to let ourselves grieve, because we grieve with our patients. We have anticipatory grief for every single damn patient we see, because almost every one of them is going to die in our care. That's the goal, but you still grieve it, and you watch other people suffer. You watch that family suffer.
Yeah.
And if you're not changed by that, if you don't grieve over that a little bit, you need to be doing something else.
I think that's something that we're really bad about. And when I do public speaking, I go through, I think there's like 7 to 10 different types of grief. And I think one thing that we don't own as caregivers is just like you said, we don't allow ourselves, it's not my emergency, it's not my family member, it's not my death, so therefore I can't grieve it. And that's totally not true. So I think we go with all of these suppressed and unpacked emotions and year after year after year, and that's why we end up in such a bad spot mentally as healthcare workers, because we don't process these things. And I don't know where we've gone wrong as far as educating. Like, you know, you both were in nursing school. I taught respiratory for 7 years. We never addressed the fact of that it's going to change who we are. We never addressed that.
No, we just studied Kubler-Ross about the grieving process in relationship to our patients, not to us.
Right. Exactly.
Right. And all of that applies to us as we move along through this. I mean, in nursing school, everybody goes through labor and delivery, right?
Oh,
you have to have a labor and delivery class. I hated it. So sorry.
So
not my thing. I would have had to slap somebody.
Let me tell you,
need to stop that yelling.
Labor and delivery was not my choice. There's a very short version of this. When I came in the military, I was ICU, trauma, anything like that, until the commander comes and says, hey, I need one of you guys to go to obstetrics. And of course, my head, I'm like, fuck that, until I couldn't get the words out because the girl next to me breaks down and cries. And I'm like, oh, there starts my new obstetric journey. There you go. Thank you.
You have to do worse than crying, pass out. So do something to get yourself out of it.
But I get what you're saying, though. I mean,
we all go through labor and delivery in nursing school. So not all of our patients are male, not all of our patients are female, and not all of our patients are going to have babies. But every single patient, every single human we encounter is going to die. There is not a class on death and dying in hospice care in nursing school. We don't do it. Medical schools are the
Why?
same way.
Yeah, but I thought medical started some of that. I know that they started like bedside manner kind of class.
That's a work in progress.
Yeah.
I'll just say that. But I think there's a dialogue. Why aren't we talking about this? Why aren't we talking about its impact on the longevity and the quality of the careers that we have?
Absolutely. Yes.
I mean, we have people leaving in droves, the silent resignation, the great resignation that hit nursing, and hospice was just as bad.
They're saying, I think between 2025 and 2030, we're going to be 500,000 short on nurses alone.
Yeah.
Alone.
Right. So the statistics for LVNs, licensed vocational nurses, or LPNs, licensed practical nurses, they lost 36% of the workforce.
Whew.
And here's the impact of that. Most of our long-term care facilities, nursing homes, are staffed almost exclusively by LVNs.
Because that all changed right when I was graduating a long, long time ago. That I was the year that graduated, and they said, oh, we're going to this team nursing thing. And that's where it started, where they wanted less. I was a BSN, right? So they wanted less of them, and they wanted more LPNs and CNA, right? Which is fine. I'm not knocking any of that. Their goals, I thought they were saving money. That didn't really turn out to be the case. But the team nursing survived, and now 30% of the LVNs walk out. That's like you said, nursing homes are majority LVNs, LPNs. And on your floors, guess who that foundation is? Because they built the teams, and you got team nursing. Right. And so that RN is over 35 patients and has a team of, 2 or 3 LVNs, like if they're lucky, and some CNAs and whatnot. And so now your foundation just walked out.
Right.
Now what, medical community? I mean,
it's funny. When I started in the hospital, I trained under the LVNs. I was a brand new GN, brand new graduate nurse, waiting for my board results, things like that. Those LVNs trained me. And these were the women with the white shoes, the white pantyhose, the white dress, and the cap.
Heck yeah.
By the time I got to nursing school, they had done away with the caps, right?
Right.
All of that traditional white stuff was gone. And I have to say that was a welcome change, because white in nursing, white uniforms, that's
I know,
just
it's so stupid.
Yeah, it's crazy.
Sure, let's do that.
So here's the kicker. When I went into hospice care 14 years ago, the first nurse I rode out with, because you do the orientation stuff, you watch the films, do the videos, and read the policy stuff that you have to do. And then they send you to ride along in community-based care to make visits and shadow someone else. It was an LVN.
Sure.
And that first day out in the field with an LVN, the first visit we made was to a patient that she had known and been taking care of for a while. And the patient died while we were there.
Oh, hell.
It was incredible.
I have maintained this, that if you take 3 nurses, take an LVN or LPN, but they used to have ADNs. I think we've done away. There might be a couple left, but the 3-year degree doesn't exist anymore. And then take a 4-year graduate, and you all move them to the 10-year mark, you wouldn't be able to pick out who's who.
That's true.
I mean, solid ones.
I worked for 28 years as an associate degree nurse.
Yeah.
I got my bachelor's degree a few years ago in my early 50s.
Yeah.
There were things that were closed to me, but I was able to do everything I wanted to do up until that time.
I used to tell when people would say, what should I do? Should I become, should I do LPN, LVN, BSN? I said, well, you got to think about your future in this. So if you'd say, I just want to be a floor nurse and that is it, I'm like, at the time, like, you can do an ADN, you can be an LPN, and you will maintain yourself on a floor, and that's it. I go, if you have any aspiration for anything above that, you have to get your bachelor's or your master's or whatever. So that's really the defining factors in that, right? But a sharp LPN that has studied and knows their clinical stuff can rock it out just as well as a 4-year RN,
Absolutely.
And I think we're missing that. I think that we are so pushing out at this point, the BSN and the masters, that they're skipping over those initial steps that you ladies took, that I took, where we started from the bottom and worked our way up.
Yeah.
And you had that experience line. Now you have these new grads who are, well, I can't do floor work. I have my BSN or I have my master's, so I'm not doing floor work. So you have these nurses with advanced degrees that have no experience whatsoever.
It's true.
And unfortunately, they are putting them into roles where they need experience. And it's not there anymore. And it's like healthcare, they've got it all backwards. Like you said, experience, you can't replace experience with a degree. I mean, you just can't.
You got to get gritty first. You got to get gritty first.
You got to get gritty first.
That's
Absolutely.
Right. I mean, you can't do it any other way, right? And on top of that, I mean, I'm kind of bringing that back to what we were talking about, is that how are you in any leadership position going to relate to your staff that is now going through these micro or major traumas, and trying to cope in either adaptive or maladaptive ways? How do you even pick up on that? Because you have no idea what they're going through, right?
Yeah, you can't value their perspective.
Yeah.
So what you have is people who are nurse managers, but are they nurse leaders? A leader and a manager are two different
Very
things.
much two different things.
Yeah. A lot of leaders are also managers, but there are a lot of managers who are not leaders.
Yeah, to be able to say, I've been there, I've got that T-shirt too, goes a long way because, like you guys said in the very beginning, you don't tell your husband a lot of detail. Because why? He's not going to understand it. It's what, and you're probably just going to stress him out because he's like, God, is she okay? Do you need some wine? What's going on? Where you could pop over to us and be like, oh my God, this happened. And we'd be like, oh, damn, or you need a hug or a glass of wine or a shot. Where are we at right now? And we're not trying to commit you.
That were applicable to the situation.
Oh yeah, the nice stuff too. Right.
So and then when you get to the end of that conversation, this is my belief, and I do this for my friends, you want that accountability. I would say, okay, this has been rough. I hear what you're saying. What are you going to do to take care of yourself?
What are you going to do about it now? That's right.
Yeah. What are you going to do to take care of yourself?
Yeah, there has to be, because you can't vent. I mean, I'll be an ear for anybody, but it can only go on for so long. Like, you can vent, but then you have to stop and go, okay, I got it all out. Now I'm looking at it. Now, what do I do about it? What do I leave? Yeah, right. And what do I need to, set down? What do I need to process later? Whatever it is, what do I need to do now to move forward? Right? Because you have to. Because if you're just going to sit there and vent, then forever, then you're not getting anywhere.
Well, I think venting becomes a gripe session, which isn't productive. Emotionally, it doesn't get you anywhere.
I couldn't stand it. One of the things that drove me bonkers is when people would always be excited to find me when they wanted to tell me some dirt. And I'm like, can't you come find me and say, hi, how are you? What are you up to? It was nice seeing your face today. Why does it have to be like, oh, guess what I heard?
I think that's another coping mechanism because, the hospitals are 100% like soap operas.
Oh God, yes.
A lot of drama.
And there's so much unhealthy. I think that we do so many unhealthy things in the hospital systems to remove ourselves from what's actually going on.
Yes. Yeah, that to me
really
was
think so.
Energy vampires.
Or we could just go back to we're just all crazy. We're just all crazy to begin with.
We're all just
my theory on human behavior. So you see how that's applicable to pretty much every situation.
Yes,
try it. You just try it.
You're
try
right.
it with anything.
So, Helen, I'm just going to end everything with, or everyone is just crazy. We're all just crazy.
So
we're all just crazy.
We have a fellow podcaster, Susie Landoffy, right? I don't know if you've met her, Helen. She was on the promo with us. She was the beautiful silver-haired lady, and she's she's a therapist. And her podcast is called Be Crazy Well. Because it's pretty much like, look, we're all crazy, so let's just do it good. Let's do it the most healthy way we can do it.
That doesn't mean
well.
she's not meaning be as crazy as you can be.
No, be
She's
crazy
meaning
well.
Be crazy and healthy at the same time.
Yes,
Sure.
exactly. So, I mean, I think we're missing that in the medical community and in general, that we just need to own our hot messness in whatever fields we're in, right? And just be like, yeah, damn it, it's a mess, but I'm doing the best I can. And it sounds like to me the hospice world is probably should maybe put together some lessons. Like, really, honestly, now that I think about it, so we might have something here. Because who better to teach about how to maintain yourself than the people that see the end of life and say, let me tell you the 10 things you're going to regret and you're going to be telling me about when you're in hospice.
Oh yeah, there are studies. There was a hospice nurse in Australia. I can't remember her name now. She did this huge study where she interviewed all these people towards the end of their lives, and she wrote a book called The Top 10 Regrets of the Dying.
Oh, I need to get that book.
Oh yeah, and it's awesome. It's all the stuff that you would think, this is what needs to be important in my life.
Okay, so we need to that's what we do, hand out the books to all the nursing students and respiratory therapists and occupation and everybody, and be like,
your job goals, it's not in your top 10.
Right.
You may think it is now because you're 22 years old.
Right.
Yeah. Yeah, your first million, and when you get it, not in your top 10 regrets when you're 85.
Nope.
No.
Nope. Just that you get to maybe retire a little earlier, but yeah, otherwise.
Maybe so.
Yeah, exactly. So, all right, ladies, because I think we could talk forever. And always a good conversation. I was excited to get Helen on. That's why I said to our executive director, I was like, she's fun. And so she goes, oh boy. I'm like, yep, me and Leslie will have fun with her.
We need to do it again and maybe do the topics. Maybe we could do the topics.
We should. Helen, that's the next one. We need to do another one. That's a great idea.
Well, we have had the conversation that we don't really fit in anywhere.
That's why we're friends, Leslie.
And this is why that she and I are friends, because we're all crazy.
Right.
But I think healthcare workers, it's a different kind of crazy.
Mm-hmm.
And it's very difficult to fit in other societal groups, because they just don't get your weirdness.
And then slap the military on top of that, and then we're just all gone.
You know,
So when you go to a party and they say, what do you do for a living? I'm a hospice nurse. I work with dying people.
And they're just like, I'm going to go refill my drink now.
Yeah, I see somebody I know over here. I'm going to go talk to him. Oh my gosh. Yeah, nobody ever asks
It's almost
me.
like,
Even in my family, people don't ask me, when I was in the field nursing, what did you do today? Oh, you don't want to know.
Yeah,
it's almost like
a huge buzzkill.
Absolutely.
If they talk to
it's
you,
a party killer.
You're kind of like the Grim Reaper. Like, if I talk to her, it might happen.
Yeah. It's true. It's true. And the bad thing is we are exactly like that. If I have somebody who's actually interested and asks me, I will tell you stories about so-and-so died this afternoon, and this is what we did. And
right.
Yeah,
we could.
It's just weird.
If it was appropriate, this is like way far, but we could have like a whole podcast on interesting end of death like scenarios. So that could be. See, her eyes just lit up when I said that.
There are a lot of people that do that. There's a huge death positive movement. There are a lot of people. You guys ever heard of death cafes?
Yes.
Yes.
Did that start in like Oregon? It's like a pod, right? Is that the same thing as the pod?
No. I don't know. So Death Cafe, Leslie, it's a movement that was started by a guy out in the UK originally. And it's just these, I think he was in the UK, may have been in the US. Anyway, so a Death Cafe is simply a meeting where you have some coffee and a piece of cake and you talk about death. And it's not grief support. It's not for healthcare professionals or funeral care people. It's just for people that want to talk about death.
And are intrigued. There you go. Go have your mocha cappuccino and talk about your favorite casket.
Exactly, if that's your thing.
Did you see? That's another one. See, this is horrible. We're going to rabbit hole this, but there's like this whole, I can't remember where it's at, but they make caskets that are custom and they're all like bedazzled or they got Elvis on them or whatever it is you want. Like they're wild ones. And I was like, oh, snap. I told my kids, I'm like, Mom's going to be cremated, but like, I'm going to have a wild urn. And they're like, oh, Mom, you're so stupid.
Oh, that's cool. Well, listen, I told my kids I wanted to do human composting, which is a very new thing.
What are those, like the fermentation farms or were they?
It's well, it's not like a body farm.
There's one
that they use.
Oh, it's different?
No, it's actually a formulation that has been made and the body's placed in a container, like a capsule type thing. And it's mixed with alfalfa, and I can't remember what else. There's a formula that they've determined is conducive for that.
You're going to feed Betsy now. Great, the cow.
So that's actually not a bad thing. So what it does, it turns into this composted soil, and the family can either have part of it or some of it to scatter or use in a garden, or it's repurposed and put out into, I guess, like a national forest where things have been, I can't remember the word for it, not reforested, but purposed to replenish the environment, the soil there.
Hey, at the beginning of life, I have had many people ask me for the placenta because they were going to go plant a tree with it. So
I have to tell you that even as a hospice nurse, I'm 100% grossed out by that.
Yeah, me too.
Wow.
I'm honored that I actually could get that response out of you. Yes. Well, then I'll one up you that
I don't even like the word placenta.
That's better than the soup that some cultures make out of that. So there you go.
Yes, I've seen that.
There is nothing more interesting than walking into the break room and there is a crock pot full of placental soup. So there you go.
I wish
She's like, I can't.
That is for countries where they're starving and they have no other option.
Okay, but I saw it here in the U.S.
Then it's wrong.
Listen, one of these days, they're so wrong. One of these days, I'm going to have selective shock therapy. You know how you have memory loss, but I want it to be selective things. That's going to be one of them. Wow.
If you can gross out a hospice nurse, I think that's pretty good.
You won for today.
I still like it after 33 years of nursing that I could still look at something and I'm like, that's just disgusting.
Yeah. Yeah. There is very few things that get me. Like I used to have people say, oh, you're a labor and delivery nurse, and like this whole kumbaya, and I would just look at them like, let me just demystify you. We're very bitchy. Just like, what?
Listen, as a nurse, as a hospice nurse, we're all about comfort. We try not to do injectable stuff.
Yeah,
that's
we're all
like
about injectable stuff.
Yeah, and the places you guys inject stuff, I'm like, that is not okay.
Inject,
that is
place,
very wrong.
Check. Yes, we have many, many, many stories.
Well, I'm respiratory. I only do the nipple line up.
But you still see gross stuff, though, Leslie.
Oh, absolutely. But I don't have to have my hands in it.
I still,
trachs.
Trachs.
The first time a patient ever coughed through a trach and it flew out on me.
Yes.
You just got to make sure you're not in line with the trach. You got to stand to the side.
I deliver.
I even asked her to cover it because I was.
I deliver 1,000 babies over trach care. God, that.
That's why there's respiratory therapists.
And that's why we have you, Leslie.
God
that's
bless
right.
the respiratory therapist.
All right. We should wrap this up. Cindy's probably like, my gosh, Dawn, I went way over. All right. So any last words here? What do you got for me there, Miss Helen?
Self-care. Doesn't matter what type of nursing you're doing. Oh, my gosh. Care for yourself. Care for the people around you.
Very sound advice. Leslie, any words of advice here?
I just want to tell Helen, thank you for sharing with us today, and thank you for your 30 years of caring for the community. The world runs off of people like you, so thank you very much for sharing with us today.
Thank you. That's so sweet.
I will resounding.
Not always sweet, but that was nice.
I like it. Now that's self-awareness.
There you go. Yes.
This was concerned. Like, I had to laugh. I was like, okay, I'm so glad I talked with Helen before I listened to her podcast, because if I would have just listened to the podcast, and her podcast is great, everybody. I'm just going to tell you, it's Heart of Hospice, and it is a phenomenal podcast. Everything to do with hospice care, and it's very well professionally done, unlike this podcast where we're just ass and elbows, just getting it out there. And so I was like, okay, Helen, are you ready? She's like, I got this. And she definitely had this. So Helen, thank you so much for coming on. And I'm glad you could come talk to us from your perspective, because that's really what we want everybody to hear, is like, we are the people behind the profession, right? We put our profession first and we do it well, but there's people behind that, and we're figuring it out too. And I want the medical community, both on the military side and civilian side, to see that and be like, damn, they're just trying to figure it out and get it done too. Yeah, we are, right? And we're all doing it in the best way we know how, and laughter and inappropriate humor and all that stuff is what gets us through the day. And so I thank you, Helen, for coming in here and being a little raw and sassy with us. And I look forward to doing more podcasts, because I can think of 2 more right now that I'm like, oh, we got more to do in the future here.
I love it. Let's do it.
All right. Okay, everybody, from all of us here to all of you guys, we want you to keep sassy and raw. Thank you for joining us on Bullets to Bedpans. You have a great week. Peace out.